So, hi everyone. Today we will present process evaluation and scale, a part of Module 5 of the advanced program. My name is Maria Lazo, and I am from Crónica Center of Excellence in Chronic Diseases in Peru, and I am in company of Min Liu from the George Institute for Global Health, Australia. Next one. So in this lecture, we will talk about process evaluation in general, then about specifically scale-up and process evaluation and some lessons learned. So nowadays we recognize the need of more and more complex interventions in global health. And once they are developed and implemented, they need to be evaluated in the field. How we evaluate them can vary sometimes. The focus, it will be in health outcomes, and in other cases, the focus will be in implementation outcomes. So it is when the focus is in implementation outcomes that we call them process evaluation. So I like these two examples where you prepare your protocol, your research idea, and you have some expectations that this will be a straight line, but in reality, you will have many loops and many different things that will go different until you find your final outcome. And similar to this SpongeBob, that you have the expectation that it will be perfect because you know the recipe, you have the ingredients, you know how to do it, but in reality, it can end up like a mess. So the key message here is that sometimes we need to understand what happened in the middle, what went wrong, what went well, to understand what happened during the implementation. Also, I would like to highlight that process evaluation is an evolving field in public health since the 60s, when we start using these methodologies. The terminology is changing, and in some cases people use the term process evaluation, and in other cases they use implementation outcomes or evaluation of the implementation, etc. So this is something that is changing over time. And another relevant aspect is that process evaluation can be used in any moment of the research cycles, informative studies to scale up. The main idea is that it's relevant to define the objective, define the methods to be used, and the theory, model, and framework that will be applied during a process evaluation. The next one, please. One more recent definition, and one of the more popular ones, is the Medical Research Council Guidance for Process Evaluation, that focus on context, implementation, and mechanism of impact. In terms of context, it's important to know how does context affect implementation and outcomes. In terms of mechanism of impact, how does the delivery intervention produce change? And in that way, spell out the key causal assumptions or the program theory. And in terms of implementation, it's important to understand what is delivered and how. And we have different implementation outcomes to be considered, like fidelity, dose, adaptation, or reach. And these three different components will help us to understand the final outcome in a certain implementation of a complex intervention. The next one. Now, in order to go more in deep in terms of the scale up, we will talk about the implementation strategies. These are actions to improve the adoption, implementation, and sustainability of intervention. So it is necessary to differentiate the intervention, that is what we implement, and the strategy, that is how we implement it. Some examples are, for example, train and educate the stakeholders or engage consumers. And to be specific in scale up, this refers to the process and actions to increase the impact of health intervention. so as to benefit more people and to foster policy and program development on a sustainable basis. You can know more about this in the module 4, lecture 4B, strategies for interventions at the scale. So some key notes for process evaluation in Scale Up are process evaluation answer the question of for whom, how, and why a certain complex intervention works. Scale Up is dynamic and heterogeneous due to the context and the diversity of populations. And for these reasons, process evaluation gain relevance. The next one. So I will present some findings and key aspects identified in 3 scoping reviews. 2 of them were led by myself and me, and one specifically about process evaluation in scale-up studies led by Ratot. So as it was mentioned, the process evaluation can be conducted in any step of the research cycle, and the objective of the process evaluation can vary according to this. For example, sometimes the aim is to implement a future study in the health system, scale up the intervention, or do future research to expand the intervention to other settings or other diseases. So the information collected for process evaluation after being analyzed can be used to be shared, to be reused, or plan the next step of a certain study. The next one, please. So the scoping review that was specific about scale-up studies identified that 17 out of the 35 studies were related to not communicable diseases. Some of the implementation strategies that were identified were the integration of the complex intervention into national or local policy, capacity building and training, resource support, quality improvement and monitoring, cultivating partnership and collaboration, transfer of ownership, and ongoing advocacy and communication. The next one. Also, most studies use mixed methods. That means qualitative and quantitative methods to report their findings. Also, we found that process evaluation study not always include a theory, framework, or model, or TFM to call them in an easy way. Those studies that most use TFMs were REAIM, who expanded consolidating framework for implementation research, the normalization process theory, and the non-adoption abandonment scale-up spread and sustainability framework, or NAS framework. And some studies use more than one TFMs to cover their needs. From this list, 2 of them are more specific about scale-up. For example, the WHO expanded has an implementation mapping tool and is a methodology that offers guidance for discussion and reflection, followed by planning for needed adaptation or other actions, while at the same time they create a record that explains how a scale-up was implemented and results were achieved. The other that is specific for scale-up is the NAS framework. So these 2 are the ones recognized and more used for in this type of studies. The next one, please. Finally, some implications about process evaluation in scale-up. So there is the need of training in mixed methods. This is based in trying to conduct a better evaluation. Then the need of multidisciplinary teams to include a more comprehensive evaluation, and define the use of process evaluation for future studies or continue scale up and or sustainability. Also, there is a scarce use of the label process evaluation, and that make difficult the search in scoping or systematic reviews, for example. There is poor use of theories and frameworks, and also we identify heterogeneous reporting of these studies that make it difficult the comparisons. So next one.
Thank you, Maria. For this next section here, I will talk a little bit about a study that Maria, myself, and Anusha did as part of a upscaling working group for the GACD scale-up projects. So based on Maria, my experience in process valuations alongside complex interventions, we knew that was very time consuming and resource intensive. So we're quite keen to learn from lived experiences of investigators from the scale-up projects as to what were the strengths and limitations of their process and economic evaluations, and how would they like to improve on its conduct. And really, secondly, how were the findings of process and economic evaluations disseminated and incorporated into scale-up strategies? So we did 23 interviews with 17 scale-up studies, and I'll report our preliminary findings from them. I've divided our findings into three kind of key domains of feasibility, acceptability, and utility. So in terms of the first domain about feasibility, whether as defined of whether it's practical and achievable, there were three key findings that came across. One is around workforce and interdisciplinary expertise. So many of the investigators reported how in process evaluations, as Maria has mentioned, there is a need for kind of mixed methods and different disciplines, and that's provided by the different members in the international team. However, it was stressed that, especially in the context of COVID, where it impacted on health workforce on the ground, infrastructure, and competing priorities, that the workforce on the ground was often stretched and limited, and that had to be kept in mind in the process and economic evaluations, but also in terms of the workforce capacity that while capacity building was a key focus of it, either through academic progression of masters and PhD students, that there was also a need for building capacity of the local staff, for example, through epidemiological courses to learn more, to be embedded within the mainstream as to how we can have a learning health system and the sustainability of it all. The second point of whether these evaluations was feasible was around funding, and that in scale up, because of the scale and the different sites that's required, that often the staff that were being used was within the existing health system and not just kind of dedicated research staff. And so funding had to include travel or include the many different staff that might be part of the project. And often that might not be enough. So there was a process in which there had to be prioritization of what would be feasible and what would not be. The third aspect was around data sources. So in scale up, I think it's very tempting to have to look at context and implementation across the scale, and which would result in a large amount of data, and then a consideration of what would be primary data, either survey or interviews, and again, how to prioritize that within the current workforce capacity and funding, and how to systematically capture context in a meaningful way, especially for projects which might have multiple country sites as well. This was again discussed that had to be feasibly done, and that was often prioritized in the initial meetings with the partners as to what could be done and what could not be done. One of the key implications in this was in the initial situational analysis, if there were areas where data sources were key to be collected, that it might be that the research funding could be used to facilitate some of that infrastructure in a sustainable way. The next finding about acceptability, which is how well the evaluations are received by partners and stakeholders, it was very apparent that stakeholder partnership was key. And this included the co-design and co-production at the start of the project, including at grant writing stage, as to what was feasible and acceptable in terms of the overall study design, but also the kind of process and economic evaluation and to what level of detail. This often built on years of trust and working together, and dissemination of findings through face-to-face meetings to share findings and to plan for future projects. However, having said that, the second thing that really came up was this kind of perceived silos, or there's a slight tension between researchers and non-researchers in terms of the perceived benefit versus value of the research findings. So again, it was whether how rigorous we want research to be while maintaining objectivity, but also what was feasible on the ground, what was useful to the end users, and what was research jargon versus health system indicators. And so I think part of that would be looking at the context of the health system, but in a way that made sense to the end users, either through the WHO building blocks of health workforce and structure, as compared to some of the implementation science research wording, which might not be understood by the end users initially. So there was this discussion in the interviews about how do we speak the same language and have the same intent in what we do, but also maintain that objectivity and enable our evidence to be of value to the end users. The third component was around cultural and social factors. So this came about in all of the scale-up studies, where it's a mix of cultural backgrounds in terms of researchers and the partners themselves, but also in terms of the discipline. So coming to terms to a common understanding and appreciating and respecting each other's expertise, but also in the context of process evaluations, where we're looking at, human behavior and context of the local health systems and broader infrastructure. Researchers in high-income countries were very mindful of the current discourse about decolonizing methods and the power imbalances around that, and ensuring that what was done was respectful and what was done was culturally safe and wanted by the research partnerships together. This was facilitated by GACD's structure, I guess, of having PIs from both LMICs and high-income countries. And often in some of the interviews was described of this, the PIs on the ground having the know-how and the cultural expertise, and the high-income country PIs bringing in technical expertise and working respectfully and in a reciprocal way to determine the best study design and methods moving forward in the research. So moving on for acceptability was around the utility of the evidence from the evaluations and decision-making processes. There were three key things that came up. One was the evidence required for decision-making, and as mentioned in the feasibility, a lot of this was around what were the data sources, but at scale up, specific for scale up, it's looking at that routine population level data and what was available, what was not, and seeing whether the researchers could sometimes triangulate the different population level data in a useful way for the end users. And secondly, in terms of the economic evaluations, it was flagged how the economic evaluations was like a toolkit where they've got different things that could be useful to the end users. But specifically for scale up, investigators reported that often it was the cost of implementation that was key, and sometimes modeling by looking at the parameters that could be adjusted to see if there's a different impact was really helpful for the end users. Having said that, everyone stressed how it's really important to tailor the wealth and the depth of evidence to the different stakeholders in terms of the level and depth and what was answering the questions on the ground. That relates to the second point about actionable items, as to whether the findings from the evaluations had were answering a policy or implementation gap. So, for example, were there concerns about stigma in their program, and if so, did they need to get more patient voices to really find out what on the ground, whether that was an issue? Other things included things like policy reviews to identify gaps and recommendations for future implementation. Lastly, it's around how it feeds back into itself from feasibility and acceptability, but about how stakeholder partnerships and trust was really key in the feasibility, acceptability, but utility of our process and economic evaluations, but how it really loops back on itself, in which the research itself, through the years of working together, capacity building, having combined outputs, could prove, I guess, the reliability and trustworthiness of the partnership. And that was even more apparent during COVID, and therefore informing future projects moving forward. So to conclude, those were the key findings across the across the three domains from the qualitative study, but now combining with some of the insights that Maria has shared. There are 4 key messages. The first one is that process evaluations are integral at scale up to understand for whom, how, and why intervention works within a complex adaptive health system. The second is that process evaluations are really integral to that continuous improvement cycle to optimize implementation strategies on the ground, bearing in mind potential feasibility issues in terms of reporting and which data to collect. The third one is that strengthening health systems and workforce capacity should be a focus outcome of the process evaluation at scale. So again, highlighting if there are infrastructure issues that need to be advocated for, communicated back to our end users, and workforce capacity should always be carefully considered, recognizing that there will be service delivery parties on the ground with research as well. And the last one is that strong, respectful, reciprocal partnerships are really crucial to the feasibility, acceptability, and utility of the process evaluations. So Maria and I thank you for your attention, and we hope that all that we've shared will be helpful to your work moving forward and how you serve your community. These are some references that we found helpful. 3 of them are reviews and lessons learned that Maria and I have worked on, and process evaluation scale up, and also the MRC guidance. Thank you very much.